Welcome. My name is Susan Ward, and I'm an ambassador for the Family Heart Foundation. I'm also a nationally board certified health and wellness coach and lifestyle coach for the CDC Diabetes Prevention Program. I've been hosting meetings on behalf of the foundation and the lipoprotein a support group. And today we have a very special presentation in our Empower Lp(a) program, and it's titled Cholesterol Connect and Cascade Screening. Okay, so today is LPA Awareness Day, March 24th, and how great is that we can actually have this meeting today to talk about this biomarker that is a risk for cardiovascular disease. Raising awareness of elevated lipoprotein a is really important to the foundation. And you can see there's a QR code in the circle, and if you want to capture that, it will work and take you to the LPA Awareness Day page on the foundation website. So I'd like to thank our sponsors. The Family Heart Foundation gratefully acknowledges the generous support of the sponsors for the 2025 Lipoprotein a Community Activation Program and Lipoprotein a Awareness Day, including Lilly, Novartis, and Amgen. So tonight we're going to have a program that is featuring Cholesterol Connect, which is a trademark program, testing program, free testing program that is available to those of you who are in the United States. Unfortunately, if you're calling in from Canada or another country, you cannot purchase this test, but we will try to help everyone find a way to be tested. And why is this important? Because 1 out of 5 people in the global population are born with this biomarker for coronary vascular disease risk, and less than 2% have been tested. I myself was tested 2 years ago, and I'm one of the people in this group that is thankful for having the Family Heart Foundation and it's the wonderful information that it provides. So tonight, we're going to talk about the test, how you can get it, and we're also going to talk about cascade screening, which is a term that refers to getting your first-degree relatives tested, because there's a good chance that 50% of your first-degree relatives may have also inherited this risk factor. So briefly, medical disclaimer for the program. This program is for your informational and educational purposes. The content is not intended to be a substitute for professional advice, diagnosis, or treatment, nor does your participation constitute a medical or coaching relationship with the presenters or employees or officers of the Family Heart Foundation. Information in this presentation may be updated or changed in subsequent presentations. Please follow up with your medical professional for specific recommendations pertaining to your or your family member's diagnosis or treatment, and reach out to a Family Heart Foundation care navigation specialist for further resources. Now, tonight, I have the distinct honor of presenting to you our featured speaker, Eric Tricou, who is a care navigator. And I want to say that we started this program with the support group a year ago this March, and Eric was the guest speaker then as well. So Eric has received his Master of Science degree in genetics and genetic counseling from Stanford University. Prior to joining the Family Heart Foundation, Eric was employed as a clinical cardiovascular genetic counselor at Geisinger. Eric has been a care navigator at the Family Heart Foundation for nearly 3 years. As a care navigator, Eric supports individuals and their family members who reach out for assistance in their journey, living with familial hypercholesterolemia, or elevated Lp(a). Eric also supports many of the ongoing federally funded research collaborations with the University of Texas Southwestern, the Dallas VA, and Penn Medicine. His special interests are focused on developing and improving family screening programs for familial hypercholesterolemia in the United States, also known as Cascade screening.
All right. Thank you so much.
I'm going to stop sharing my screen. I'm trying to get that to work here. Okay. Yes, here, Eric, here you are. And I hope everyone enjoys this presentation. We have a lot to learn from Eric.
Thank you so much for that introduction, Susan. It is a pleasure to be back talking at this group again. It was a full year ago where I kind of started off here with a much smaller group, and it's great to see how this has been growing. So also very serendipitous timing to be able to speak with you all on Lp(a) Awareness Day. Pull up my slides here and give me just a moment. All right. So let me get started here. All right, so just to start off, as the title of this presentation mentioned, I wanted to really highlight our Cholesterol Connect program that we launched here at the Family Heart Foundation. This is a very unique program where we are coupling at-home testing for both Lp(a) and LDL cholesterol, in addition to the other components of your standard lipid panel, including triglycerides, total cholesterol, and HDL. One of the things that really makes this program unique is that not only is it free screening, which you can do at home, and we'll talk a little bit about that, but it is also inherently coupled with our Care Navigation Center. So as Susan mentioned, I am a Care Navigator. I'm one of 3 of our Care Navigators here at the Family Heart Foundation, where after individuals get their results, we are able to work with you to understand what these results mean for you and help you get connected to the care you need. To find the test itself, you can go to cholesterolconnect.org, where you will just put in your information for where the test is shipped and your contact details, and that kit will get sent out to you. It is limited to 1 per person, but if you have multiple individuals living in the same household, you can order additional kits for your relatives. Just ask them to go in and complete the form themselves, putting in their name and their email address, and we'll get those kits sent out to you. Also very exciting, we did recently launch a Spanish version of our Cholesterol Connect website. So we are now able to not only support English-speaking individuals, but also trying to make inroads into communities that may not have traditionally engaged with us in the past. So we have a full website specifically in Spanish, and the entire process is in Spanish. And if the results come back, we are going to be able to deliver care navigation in Spanish as well. So very exciting for us here at the Family Heart Foundation. So as I mentioned, this is a free at-home kit. It comes in a box like this, where there are contents inside, including the test kit itself, some lancets, a couple of alcohol swabs to clean your finger, and instructions and a brochure for how to complete the test. I've gone through this myself. It's not too bad. Essentially, there are some tips and tricks that will go over for completing your test, but you essentially just prick your finger, drop a few drops of blood onto the sample collection card, and you register the test kit online, and they give you a prepaid mailer to return the test back to the lab. After you order the test, it'll take about 1 week to get to you. And after you return that in the prepaid mailer, it will go off to the lab. Once the lab receives that, it takes them a day or 2 to process the test itself. And then your results will be available to you in a personalized results portal after the lab discloses those results to you. And that will also take into account things like other risk factors, which can give you a bit more personalized guideline-based recommendations for what goal LDL cholesterol should be for you. The After that, if the results are flagged as high, or if you just want to speak with somebody to learn more, there's an option to schedule directly with one of us care navigators. Those care navigation appointments are usually about half an hour to 45-minute Zoom calls. It really depends on what your specific questions and needs are. And we can do all sorts of things like help you get connected to specialists in your area, help you understand the general recommendations for goals for treating LDL cholesterol specifically, and more resources on how to stay informed about what's happening in the lipoprotein A world. Things like if you're interested in clinical trials, we can get you signed up for clinical trial alerts. It really is whatever you're interested in. We just want to be there to help facilitate you as you are navigating your results. And anyone here who hasn't had their LPA test, if you do have relatives who are interested in testing or screening, they can always reach out beforehand as well if they want to talk more about the testing and the testing process before committing to testing. And again, this is all at absolutely no cost. It is totally free. And that's one of the really unique things here. It's not only just, yeah, like I said, that free testing, but also that personal component to really support you along the way. A couple of things here for anyone who might not have done the sample collection yet, just to give you a few tips to make this process go a bit easier for you. Making sure you are well hydrated, drinking water beforehand. One of the key things is to warm up your hands. That can improve the circulation and make the process a whole lot less painful. We've had a couple of people who reached out and had to use multiple lancets. They weren't able to get enough blood on the collection card at the time. So we really just want to give you a couple of tips to maybe save you a couple of pricks on your fingers here. You'll also just make sure you have all the contents from the test kit in one place. They give you a great instructional video on how to complete the collection, and then just making sure you register your test kit in the online portal before returning it are all great tips to keep in mind if you go forward with this testing, or for your relatives to remember. And these are all also things that are included in the brochure. There is one caveat where, due to state laws, we are unfortunately not able to deliver these test kits to 3 states. That is New York, New Jersey, and Rhode Island. And that really is coming down to state-specific laws for what at-home sample collection is allowed in those states. So I wanted to bring up some alternatives. I think one of the easiest ways is asking your doctor for this test to be ordered. Again, Lp(a) is not something that is included as part of your standard lipid panel. And there is a CPT code that you can bring in for your doctor, specifically requesting lipoprotein A to be tested. And that is listed there. It's 83695. And often the cost of that is $30 or less. Usually insurance will cover it. But if you want to go the route of ordering the test yourself, there are a couple of options as well for individuals in these states. We have no affiliations with these companies, so we can't attest to what exactly the process looks like, but I did want to provide some options there if any of you live in these states or you have relatives living in these states. Let's Get Checked is a home test kit that is similar to the kit we use, and that's $89, and that also includes a full lipid panel in addition to lipoprotein A. And then there are a couple of lab draw options run by both LabCorp and Quest Health, where you can order these tests yourself. The LabCorp option, I looked it up today, and that is $49 to order lipoprotein A for yourself. All that happens there is you order the test online, and then you set up an appointment at the nearest LabCorp or Quest location and go in for the blood draw. So it's a bit more steps involved, but it is an option for people who might not have access to the Cholesterol Connect program that we are running here. And again, as I mentioned, we do have 3 care navigators, myself as well as Ann Dodge, who has decades of experience as a pediatric lipid specialist, and Aurora Sullivan, who has a public health background. We are all available throughout the week. We live in multiple time zones, so we really want to make it as convenient as possible for people to be able to connect with us. So we really hope that you see how easy and streamlined this entire process is. Okay, so with that groundwork laid about the Cholesterol Connect program, I want to talk a little bit about our other topic today, and that is about Cascade testing. So we will get into the process of helping your relatives get testing and strategies for helping relatives get tested. But I think it helps to set the groundwork by talking about the inheritance of lipoprotein A. And I don't want to get too far in the weeds with some of the genetic stuff, but I'm a genetic counselor, so I'd be remiss to not do a little bit of nerding out on some of the genetic components of lipoprotein A. Okay, so before we get into that, just as a reminder, as Susan mentioned, LP little a is a pro-atherogenic, which means it can cause atherosclerosis or heart disease, cardiovascular disease, heart attacks, and strokes. It is pro-inflammatory and pro-thrombotic, so it can lead to pro-clotting processes that happen in the body. So we really think about LP little a as a kind of triple threat when it comes to its risk. What is considered normal for LP little a? We tend to follow the American Heart Association and the American College of Cardiology guidelines of what we consider elevated to be above 50 milligrams per deciliter or above 125 nanomoles per liter. One of the things, Cholesterol Connect, we measure in nanomoles per liter, but if anyone is having testing elsewhere, if you've previously had testing elsewhere, some labs measure in milligrams per deciliter. So what's considered high is really dependent on what units the lab is using to measure LP little a. We consider normal anything below 75 nanomoles per liter and below 30 milligrams per deciliter. And some of you might notice that there is what is considered kind of a gray zone in between that 75 and 125. And those folks might be at somewhat elevated risk, but not as elevated as individuals with an LP little a above 125. Okay, so the genetics of lipoprotein
Down
A.
at the bottom. They're not for you.
Oh, hold on.
I'm borrowing them.
See if I could. Oh, okay. All right, so on the right here, just to orient you, a lot of times you'll hear lipoprotein A called a LDL-like particle. And what they mean when they say that is there's essentially an LDL-like lipid core that is made up of various lipids and contains cholesterol. There is an ApoB protein wrapped around that LDL-like lipid core. And then attached to that, this kind of C shape, reverse C shape you see on the outside here is an ApoA protein. And that's bound to that ApoB protein by a disulfide bond. And this ApoA is really what makes LPA different from LDL. The LPA gene is what codes for this ApoA protein here. And as you'll see, we'll get into a bit more of the structure here, but essentially there are all of these Kringle domains, which is what K stands for. And those domains are numbered from K4 through K4 subtype 1 through K4 subtype 9. And those Kringle domains, they got their name because they look like Danish Kringles when they look at them under advanced imaging techniques. Where LPA came from, specifically the ApoA protein came from, is we think it is a example of something that kind of evolved from the plasminogen gene based on structural similarities to plasminogen. So plasminogen is a protein we all have in our body. It's the precursor to plasmin, which helps break down clots. And when you have a clot, that plasminogen receives a signal to turn into plasmin, which is what's actually breaking down those clots and helping clear them. The P domain, or protease domain, is the active site for actually breaking down these clots. So that P domain up here. And when we start to look at the similarities here, what they actually noticed was there's a lot of structural similarities. So somewhere along the line of evolution, I think 30 to 50 million years ago, this gene replicated itself, lost these first three domains, the first three Kringle domains, and then this Kringle 4 domain started to duplicate. It duplicated many times over the course of evolution, and this Kringle 4 type 2, you will hear that referred to a lot when we're talking about the genetics of lipoprotein A. So Kringle 4 type 2, this is a like piece of this gene that can have many different copies of it. And it can vary from only 2 copies to over 40 copies of Kringle 4 type 2 domains. And that's what leads to the vast array of differences in lipoprotein A genes when we look across hundreds and thousands of individuals. So thinking about that Kringle domain, what we see is that when people have fewer of those Kringle 4 type 2 repeats, they tend to have smaller overall ApoA proteins and subsequently smaller LPA particles, which leads to a higher LPA. So there's this inverse relationship where when people have fewer of the repeats, they have higher LPA. And on the opposite side of that, when people have a lot of repeats and they have these very large LPA molecules, we actually see lower LP little a. So just remembering more repeats is lower LPA in the blood, fewer repeats, higher LPA in the blood. And that accounts for the vast majority of the differences we see in concentration. So people who have had very low LPA measured, you probably have much larger LPA molecules. But that's not the entire story. There are this graph here, it's a little busy, so let me just orient you to this. This shows the large variance of LPA even within each isoform group or repeat size. So isoform is essentially thinking about how many different Kringle 4 type 2 repeats a person has. So this graph on the x-axis at the bottom here, we have the lowest number of repeats a person has, and then what their LPA concentration is in the blood. So we see at the very high numbers of repeats, people generally tend to have very low LPA. At the lower repeats, we can see a vast array of differences here where some people have very few repeats, but have very low LPA too. So there's something else going on beyond just the Kringle repeats, which seems to moderate the effect of these Kringle repeats when we're looking at a person's LPA concentration. And one of the other things there, so we talked about the repeat size. This is another slightly busy picture, but let me orient you to this. So in the middle here, we have, again, the structure of the LPA gene. Right here, where you see this orange 2, that is the Kringle 4 type 2 domain. And this entire rest of the gene on the top and the bottom, we see other genetic changes that we know are associated with either increased LPA or decreased LPA, irregardless of what the number of repeats they are. So not to overwhelm you with the specifics of the genetics here, but I really just want to highlight that this is one of the main reasons why we don't really do genetic testing for LPA, is just because of the very complicated genetic architecture. And it's not fully understood exactly how many of these different interactions between the Kringle repeat size and other variation elsewhere in the gene, and the interplay between those factors affects the final outcome. So best case scenario, we always just want to measure blood concentration of LPA. And that's what's going to be most important for you or your relatives as well. So even though we're talking about a genetically determined causal risk factor for heart disease, we don't really do genetic testing beyond just a research basis right now. So with that said, how is LPA inherited? Many of you might recall the different inheritance patterns from biology class doing Punnett squares. The two classic patterns are dominant and recessive inheritance. LPA is an autosomal codominant pattern of inheritance. So if we think about dominant, what dominant inheritance means is a person having a single genetic change in one copy of a gene is enough to cause that individual to have that disease or trait. So that one mutation dominates over the other to determine if a person is affected or not. In recessive conditions, a person has to have two mutations, one that they inherited from mom and one that they inherited from dad to lead to that person having that condition. Autosomal codominance is unlike traditional dominant in that both parents' LPA genes are expressed. So I like to think of it as it's almost more additive than just one mutation dominating over an other. So it's the combination of what you inherited from mom and the combination of what you inherited from dad meeting together to determine what your lipoprotein A is going to be. So in this figure, this is what's known as a pedigree. Pedigree is a tool that is used to draw out family trees and understand who's at risk in the family and who should be tested. This arrow pointing here is pointing at a individual who has an LP little a of 355 nanomoles per liter. They are fully filled in because looking at the generation above, we don't know the next line up is the grandparents' generation. People that share a line here, these are siblings. So these are siblings with the individual who has the 355 nanomole per liter LPA. So people who only inherited one mutation that is causing high LPA aren't going to have as high of LPA as someone who inherited two mutations that are causing very high LP little a. So you can think of that going back to Kringle's up top here, maybe grandpa or the father had one small allele and one large allele, same with the mother, one small and one large, and the child here, the person with 355, inherited two small alleles, which led to a very high LPA, while their sibling here with only an LPA of 225 only inherited one of those high-risk alleles. And this has implications for when we're talking about the risk for relatives. So in a true autosomal dominant inheritance, it's always a 50% risk for your close blood relatives to also have high LPA. So that means if you have high LPA, parents, siblings, children most likely have a 50% chance of also having high LPA, but some people might be at even higher risk, which emphasizes the importance for those with really high LPA. It really is important to get your kids tested as their risk would be much higher. Okay, so let's talk about cascade screening now. So cascade screening is a term where we use to, it's the process of informing your family members of a genetic condition discovered within the family, followed by supporting those family members getting tested for the condition. So cascade, thinking about it like a waterfall, we start with testing close relatives, and then it cascades out to more distant relatives as we identify people who are affected. So as I mentioned, if you have high LPA, your siblings, parents, children all have at least a 50% chance of also having LPA and should be screened. One important thing to note here, and we'll get into this, is that just because of how common LP little a is, being 1 in 5 people have high LP little a, even if a relative tests negative for LPA, we would still probably want to keep cascading out just because we don't know what they're inheriting from the other side of the family. Okay, so I want to talk a little bit about how I generally help support people who are looking to get family members screened. And I kind of laid this out in a stepwise fashion, and everybody's family is different. So some things may work, some might not, but I just wanted to kind of give you a basic template for how you might go about getting relatives screened. And at the end here, I want to share some experiences of that and hear from you all of whether or not you've talked to relatives, how that went. But we'll save that for our discussion at the end here. Okay, so After today, I want you all to prepare the information you'll need ahead of time. So have resources available for how they can get tested. So Cholesterol Connect, if they're in one of the states where we offer testing. It's helpful to print out letters and infographics for relatives. We have a bunch of those on our website, which I will walk through as well. Having your test results ready can be helpful to inform them, and knowing details about the family history can also be useful as you are thinking about kind of conveying this information in an effective way to at-risk relatives. So one of the tools we have is we have this family tree here, which might be a good way for you to organize which relatives are have been tested, who hasn't been tested, were they diagnosed with LPA, is there other history of high cholesterol, heart attack, stroke, and how early that happened. Again, this is a pedigree, so you have you in the middle here. Sisters are in the same line. Above that line is your parents' generation, so your mother and father. And then off of your father, we have your paternal grandfather and grandmother, and your maternal grandfather and grandmother. And you can expand this out depending on how many siblings, children you have, whatever fits your family. Let me go forward here. So after you kind of sketched out your family tree and thought about who you want to talk to, identified who might be good candidates for screening, it's a good idea to think about how you want to communicate this information with them. One of the things I like to recommend is actually at a family gathering. I know health information isn't often talked about at holidays or things like that, but if there is an opportunity where you have a lot of family members together, it might not be a bad time to mention, hey, I was found to have high Lp(a), and you all should talk to your doctors about getting testing or go through Cholesterol Connect to get testing. We know family dynamics can definitely be complicated, so family gatherings aren't also always the best place to talk about health information. So sometimes a face-to-face, one-on-one conversation is preferred. Some people prefer phone calls or text messages, and emails and letters are also a great option for communicating this information. And you can use different strategies for different members of your family. Again, closer relatives, it might be easier to just bring it up to them the next time you're speaking with them. More distant relatives might be more appropriate for an email or a letter. So after you have your family tree and you've thought about how you want to contact your relatives, the next step is considering your messaging for how you want to raise this information to your relatives. And there's a lot of points to consider there. And there's some different resources that I want to go over as well that might shape how you think about communicating this message with your relatives. And first of all, the first thing I'll say is this information can be dense and complicated. We are always here to help facilitate family screening if that's something that you would be interested in as well. So one thing that I found can be helpful with messaging is recruiting other family members to help reinforce the messaging. So oftentimes in families, there will be a individual who is kind of the leader of the family. Often, especially when it comes to health issues, there's some matriarchal figure who is the one that is able to kind of corral the rest of the family members to get screening or take this seriously. So if there is someone in your family that you think this messaging would be effective coming from, think about that person as maybe the first person you approach with your family screening. One of the things that can be helpful is also sharing your experiences. So do you have a history of some event that led you to actually getting your LPA tested? Sharing the experiences beyond just, I have this high LPA, it's a risk factor for heart disease, you should be tested. Sometimes making it much more personal about what it meant to you to get tested. Sometimes if somebody finds out they have high LPA and it kind of pulls the entire family history together, that can be a relief to finally have an answer to what's been going on in the family. And sometimes it can be stressful, but talking about how you were able to get through that stress and empower yourself to take control of your health can also be ways to show people what they might be able to expect from screening. One of the other things we've talked about a lot before at the Family Heart Foundation is fear and efficacy messaging. And this is something that comes out of what is known as the extended parallel process model. And it is a way to message where we find family members may be more prone to pursue cascade screening if there is this kind of double-sided message, one side being fear in that we don't want to scare them, but we want them to know that this is something that can cause heart disease. This is something that can lead to stroke. There is a real threat, but we need to couple that with the efficacy messaging that there is something that they can do to reduce their risk of heart attack and stroke, or something that they can do to uh, stay up to date and informed when if new therapies come out for LPA, that they will be able to reduce their risk for heart attack or stroke. So there's a lot of ways to frame that, but it really is, we find important to kind of use that messaging. And for some family members, this might not be the best approach. Some family members who already have a lot of health anxiety, maybe framing it more on the efficacy side, that there are steps they can take to reduce their overall risk by knowing they have LP little a. Oftentimes, you can also emphasize the benefit for children. So I've worked with families before that they have a brother who doesn't really go to doctors. The person kind of waved their hands, kind of hoo-hooed on the message when they were told that they should be tested. But saying that not only is this information important for you, but it might have implications for your children's risk. A lot of times people will take steps for family screening knowing that it could provide more information for their children. So even if it's not out of their own personal benefit, seeing the benefit for other family members could be one lever you can pull on to help motivate people to pursue cascade screening. One of the other things right now, especially with Cholesterol Connect, is kind of leveraging the power of free. So saying, hey, you can get this test, no cost, it'll come to your house. You can get free assistance from care navigators. It's a lot of times people sign up for things when they're free. So I think we have a unique opportunity to kind of leverage that to also encourage people to pursue screening now as opposed to sometime in the future. And of course, like I said, your family members. Certain messages will work for some and not others. And if that's something you ever want to talk through, again, our care navigators are here to kind of help you craft messages or think about how to approach different family members and strategize and game plan for getting your relatives screened. So then following through, it can be helpful to set deadlines or reminders to encourage family members to complete testing after they've ordered a test. It is something that I know many of my family members, I encouraged them to get testing, and then I went and visited them 6 months later and saw the test kit was still sitting on their counter. So when you're talking about a game plan for relatives, coming up with a date that they think they might be able to get the test completed and sent back in. You can make an event of it. You can offer to assist with the test collection if it's someone close to you. Have a bunch of relatives come over and all get tested together. You can all prick your fingers together. Creating accountability within the family. So using messages like saying, we're all going to be doing this test on this day. Can we count on you to also participate? And really framing it as accountability for health for the whole family, and not necessarily their individual circumstances, if that messaging works better. And then also supporting family members when the results are returned by not only just giving them the empathetic support that you would anyway, but also giving them good, robust resources from the Family Heart Foundation saying you've heard from us before, we were able to help you, and we'll be able to help them. Kind of having that soft handoff there can be helpful as well. So to help you with this, one of the things I mentioned earlier is one of these, the family sharing tools, which you can see on familyheart.org/family sharing tools/LPA family tools. If you go to our website and you look at resources and you go to toolkits, that's where you'll see the family sharing tools. We've put together a number of things. So one of the things that we like is this personal letter. So this is a one-page letter that really outlines the risks of LPA, how they can go about getting tested, why they should be tested, and what their healthcare provider needs to know. And you can personalize these for relatives if you want to go the letter route. Additionally, we have a text message draft that we've made it much more short and concise that you can use as a starting point to text message family members, or if you want to send them a much shorter message, you could use this. And the background conversations with family members. This is a longer document. This is just the first page, but there is, I think this is a few pages long, and it has more details about the specifics of LPA, what the risks are, why they should be tested. So if you have family members who are really information seeking, this might be a great way to kind of guide a conversation between them. And of course, we are always here to help you or your family members. It's always free care navigation. Just talking to us doesn't mean they have to commit to testing. Sometimes it can be helpful if they hear it from someone that's not in the family. Sometimes it might be one of those situations where it's a concept called source authority, where hearing it from a specialist or someone who's outside of the family can help reinforce the importance of getting tested. And I just want to cap this off before we get into our discussion about what's been tried in the past, what's worked, maybe what hasn't worked, by talking about my own experience with getting my family members screened for high Lp(a) using Cholesterol Connect. So I joined the Family Heart Foundation about 3 years ago, and at that time, even though I knew about Lp(a), I had not had my Lp(a) tested. It took me about a year of working here before I was able to get my LPA tested, and mine came back undetectable, which is very common. About 20% of people have essentially undetectable Lp(a). So I was like, okay, that's fantastic. But I did know that there was still a family history of heart disease, specifically on my father's side of the family. So as soon as we launched Cholesterol Connect, what I chose to do is I actually started a group text message with 4 or 5 of my relatives and said, hey, here's this great program we're running at Family Heart where you can get a lipid panel and your Lp(a) tested. And I encouraged all of my relatives to sign up for the test. My father, he ordered the test, and he is the person I was talking about, where I went to his house about 3 or 4 months after he had ordered the test initially, and it was still sitting there. And I said, Dad, you really gotta drop this in the mail. And we had a conversation there about the family history of heart disease. His mother, my grandmother, had had many stents, and in her 50s and 60s, my dad was brushing that off, saying, oh, yeah, but she was a smoker, she had diabetes, all these other risk factors. And I said, yes, while that may be true, there's still a family history here, and we know it's a risk factor for heart attack and stroke. So he eventually sent it back in, and it turns out his Lp(a) is 140 nanomoles per liter. So he called me back up and he said, I guess you were right. We do have this in the family. It started making more sense as we started talking about other individuals in the family who had had atherosclerotic cardiovascular disease. And we kind of came up with a game plan for talking to other relatives there. So after he got his result, I set him up with a specialist. I told him who he should go see in his area. He said he would go see them, and I encouraged him to start sharing this with his siblings as well. So we are kind of now dividing and conquering in the family to help get additional family members screened. So it was a long process. I think it was more apathy than anything that took my father that long to get tested. But I think that also highlights the kind of gentle nudges. I wasn't going over the top, texting him every week saying to send it in. it really was just kind of getting a sense of kind of where he was at with it. I think when we think about stages of change, he was in the pre-contemplation stage for a while and then finally ordered the kit. But even after the kit got to him, he was going back and forth on whether or not it was actually important. And I was able to just offer gentle nudges at certain times when he seemed receptive to hearing it. So it is a long process. It can take a while. Some relatives you'll tell about testing and they'll jump on it right away. But it can be a very different within families, and I'm still working on other relatives. So even as someone who specializes in this, I can absolutely appreciate how difficult it can be to help family members get screened. So I want to take a minute here to first of all do a little bit, if there are any questions about anything we talked about, I'm happy to answer those. But then I really want to shift our discussion to talking about what might have what attempts you've made to speak with your relatives about family screening, what's worked, what hasn't worked, tips or tricks that we can all share as a group to think about how we can help spread the word here. It looks like, sorry, I didn't have the chat up, but it looks like there were a lot of conversation in there. So let me take a look. Okay, so from Kyle Nash, if someone has high LPA, prothrombotic variants like F2, okay, does that change how urgently we should act? So I will say I am not familiar with what F2 is there. I can look into that and maybe reach out to our chief medical officer to see if he's ever heard of any interaction there. I will say if you are in Chicago, we do have a number of great specialists in the area who we could more than easily help you get connected to, who could take a look at your personal risk factors, taking into account other prothrombotic risk factors you might have to come up with the best approach for yourself.
Eric, would you like me to read you the questions, or do you want to?
Yeah, that'd be great. If you could, that'd be great.
Yeah, so there was one question, a couple of them have already been answered. The one who asked from Canada, can you send it there? And the answer is no, we can't. And I think the only solution there would be if they had a relative in the US, then we could deal with that. But you can't do that across the country borders. The other one was about if you live in New York, what do you do? And Jen has already answered that, go, see your doctor. But we also had those other sources of information that you put up there about the, getting it through LabCorp or through Quest on, on demand. Then the other question here is if someone in their 30s tested negative for LP little a, can that change as they get older? And of course, you might have to explain what they're.
Yeah, that's a great question. So LPA is very stable throughout a person's lifetime. Usually as young as 2 to 5 years old, a person's LPA will kind of reach the level it's going to be at throughout their entire life. There are a couple of caveats to that. So sometimes there can be acute injuries that lead to a temporary spike in LP little a. But usually once you have your baseline, it's not recommended to be retested. We kind of bucket people as normal, moderate risk, that kind of in between, and high risk. And people usually don't move between categories. So if you're high, if we retest you, you're still going to be high. Sometimes women can see a elevation in LPA around menopause by as much as 10 or 20%. But for the most part, no, we don't recommend retesting LPA. If it's good, usually not going to change as you get older. And that's another thing that can be helpful with Cascade screening, talking to your family members, say, hey, look, it's a one-time test. If you get it done now, you'll never have to get it done again. That might change if medications come out and they want to track it. But as of right now, the guidance is once lifetime test because it is incredibly stable throughout a person's lifetime. Now, with that said, there can be some minor variations just based on the day of the week. There can be fluctuations in a person's LPA level, but it doesn't change enough to usually move between risk categories. So if you're high, even if it's a little lower one day or a little higher another day, usually you're still going to be in that high bucket and should be treated as high risk because of that.
So we have a couple of questions around children. One person mentioned they have a 16-month-old, and then another question was how young can children be tested? I've heard that LP little a is set after about age 5. Is this true?
Yeah, so LPA is set about after age 5. As far as if children can be tested, they can. It is available for this Cholesterol Connect program. People are testing their children. I think there's a couple of things to consider there, and that is a important discussion for you and probably your child's pediatrician and kind of how you would handle the information yourself. I've heard some people that some specialists take the approach where they will test children if the child has other risk factors. So, for example, for children with FH, familial hypercholesterolemia, some clinics will also check for LP little a. But there's no guidelines when it really comes to children. So that is more of a choice between you and your clinician or physician at this point. Um, with that said, children can be tested, and usually once they have that information, it'll be set for life. And then sometimes parents want to take the approach of set them up with as much information as they have going forward, especially if you can start talking about it young, the importance of maintaining heart healthy habits, even though lifestyle and diet aren't going to change LP little a. It might be something where you can work on instilling the importance of managing other risk factors or maintaining an active, healthy, cardio focused lifestyle, good diet patterns that, again, aren't going to change LPA, but can establish good habits early. So
Okay,
sorry, that's a little vague of an answer, but the answer is it depends. But children can be tested, yes.
thank you, Eric. Here's another one. How would you respond to a family member who won't get tested because there's nothing that can be done to lower LP little a, so what's the point in getting tested?
Yeah, I think that's a great question. And we hear this from many different angles, from not only family members, but also I've talked to doctors before who are of the mindset that since we can't treat LPA, why would we test for it? So that's a very common response. And I think what I usually say to that is that even though we can't directly impact LP little a, it can be used to inform choices regarding how you manage your other risk factors. So, for example, one of the most targetable risk factors for reducing your risk for heart attack or stroke is LDL cholesterol. LDL cholesterol, anyone who hasn't had a history of a heart attack or stroke, we want that LDL below 100. Somebody who has an LDL of about 120, for example, might be saying, that's kind of borderline high. That's in the noise. I'm not going to take it that seriously. But if they learn they have high LPA, that might motivate them to be more aggressive about lowering LDL. For every 40 points we lower LDL, we reduce that risk of heart attack or stroke by 20%. So that same thing can be said about how seriously they take their other risk factors. And I also think it's just knowledge is power. Some people don't want to know that they're at risk, but I also tell people if even if there's nothing that can be done about it right now, knowing you have that risk factor can get you clued in early as we start to see some of these LPA lowering medications come to market, and you can inform yourself, stay up to date on the latest news, and potentially enroll in clinical trials if any become available. I think the other thing there is, again, talking about uh, this is something that's not part of guidelines. And again, I'm not a medical provider, but there is some evidence, some doctors out there are taking the approach of using daily baby aspirin in people with very high LP little a. There is some evidence that aspirin can reduce the risk of heart attacks or strokes in people with high LPA. So I think I would counter that, essentially to sum that all up, is even though we can't target LP little a directly, we can target other risk factors and potentially stop them from having a heart attack or stroke.
And that leads us to the next question, which is what can you do to support LP little a naturally with lifestyle, nutrition supplements, digestive enzymes, exercise, etc. We know that exercise and a healthy diet are important, but they do not change the LP little a
Yeah,
very much.
exactly that. It's incredibly resistant to lifestyle intervention. So there aren't any ways through diet, supplements, lifestyle that lower LPA um, that would really be recommended. There is like niacin, for example, at very high doses does lower LPA a little bit, but niacin is um, comes with a whole host of other problems. So most specialists wouldn't recommend anyone take niacin. Um, there's some evidence that was it estrogen can change LPA a little bit. But with everything that we've seen, medication and otherwise that changes LPA, it hasn't been enough to shift the number to actually reduce the risk of heart attacks or strokes. Like I said, niacin might see 10-20% reduction, but what we really need to see, what the evidence is pointing towards, is to really reduce the risk of heart attack or stroke, is we need to drop that LPA by over 60 or 70%. And then medications that are currently in clinical trials, we are seeing as much as 80 or 90% reductions in LP little a. So right now, there's nothing that would really be recommended or supported by the evidence when it comes to nutrition, supplements, exercise, or any of that. But all of those things are still absolutely important for maintaining a heart healthy lifestyle. So exercise is great for overall cardiovascular health. Eating a great diet improves a lot of other metrics and can help protect your heart. So it's not to say throw up our hands and do nothing, but there's nothing that's going to change that LPA.
So in your cholesterol connect testing, do you include ApoA, which is really the high density lipoprotein, and ApoB, which is ApoB 100?
So we do not. It is only your standard lipid panel with LP little a. And that does so without getting too far into the weeds of advanced lipid testing, for the vast majority of people, having a lipid panel and your LPA can give you enough information for your provider to make shared decisions with your provider when it comes to managing your heart health. Um, yeah, so we don't. I can. There's the whole other conversation that could be had about advanced lipid testing, but no, we're not testing for that. And what we are testing for does give a pretty robust image of what your overall risk factor is attributable to these lipoproteins.
Okay, we have another question. Is the LDL below 100 target the same for all people, regardless of height and weight?
So can you repeat that? The LDL below 100?
Is LDL below 100 the target the same for all people, regardless of height and weight?
Yeah, so regardless of height and weight, yes. But there are with LDL targets, there is the guidelines. We actually have a great website that I'm going to make a plug for. It's our Safe Zone. And let me pull that up and drop that into the chat here. But this is a great way where you can go see kind of how these guidelines recommend LDL. If somebody has a lot of other risk factors, like they have diabetes, hypertension, they are obese, a doctor might recommend a lower target LDL because we do know all the evidence points to lower is better. But at baseline, the general guidelines are if you haven't had a history of cardiovascular disease, below 100 is where you should be. If a person does have cardiovascular disease, if they've had a history of cardiovascular disease, the recommendation is below 70. Again, that can be moderated even lower if they have additional risk factors. And for people who have multiple high-risk conditions and also have cardiovascular disease, the targets are below 55 milligrams per deciliter. So that is another thing that's important to tell people when you speak with your doctor, to have them give you a target of where they would like your LDL to be. Oh, LDL is measured in milligrams per deciliter. I just saw that come in.
So again, is this testing available overseas? Obviously, we can't ship overseas, but there are tests that are available overseas in different countries. You just have to find your provider and go from there.
Yeah, not as familiar with the Canadian healthcare system, unfortunately, to say if there are ways to expedite that.
Also, there's somebody who asked about the 16-month-old, and I think
Yeah, I would say 16-month-old, that's too young. Usually LPA will reach, I mean, so even people that test children, I don't think anyone would recommend testing a 16-month-old. There are fluctuations that happen, but usually it's stable around age 5. So I think that would probably be the youngest a provider would recommend testing if they thought there was a need to test in a child that young. But yeah, 16 months is not going to be reflective of what their kind of baseline LPA is going to be.
okay, here's another question. Do you find the NMR test to be useful to predict risk?
NMR test. I think what is that? That's the
I think that's a particle count.
particle number. Okay, so is that again advanced lipid testing?
Mhm.
Okay, yeah. So advanced lipid testing, it can be helpful. Usually when we're talking about advanced lipid testing, we are looking for something known as discordance. So there was a lot of, so we do know, first of all, particle number is a more accurate prediction of risk. That's why a lot of the LPA assays, for example, have moved to particle number over just total molecular weight. The I think NMR, is that also the one that does like the different particle size? Yeah,
Maybe. I think so.
I think so. Okay. Yeah, so there is some evidence that particle size is important when it comes to things like LDL. I think it is more often they're looking for what's known as discordance. So this is when somebody has a high number of particles, but a low molecular weight of LDL particles. In those cases, often when people they have a lot of other risk factors, like they're severely overweight or obese or have diabetes or insulin resistance, that's usually when we would see that kind of discordance where the particle number isn't matching up with the overall molecular weight of LDL cholesterol. Again, for most people, a standard lipid panel and LPA is sufficient. When we're talking about particle number, just to familiarize everyone else, so every LDL particle and every LPA particle, they all have that ApoB protein on them. And that ApoB protein is one of the key players in the atherogenic process. So a true better overall predictor is understanding the total amount of ApoB containing particles. But with that said, most people will be able to understand their risk appropriately with a standard lipid panel and LPA. And there's a lot of nuance there. I think Dr. Dayspring has some hot takes on measuring ApoB and particle number over a standard lipid panel. But it's a little in the weeds. I think I'd be happy to talk more about that. If you want to reach out through Care Navigation, we can dive down that rabbit hole. But yes, NMR can sometimes be more helpful in predicting risk, but not for everyone.
Okay, let's move on to the next question. It's a situation I have. The person writes 100 milligrams per deciliter of LP little a. I lowered my LDL-C to under 50 milligrams per deciliter with statin. Am I still at high risk for CVD with high lipoprotein A?
Yeah, so we're talking about the risk attributable exclusively to lipoprotein A. Yes, we do know all the evidence points to LPA being a independent causal risk factor, but cardiovascular disease in general is a multifactorial disease. So by lowering all of your other risk factors, you have likely significantly mitigated your overall risk, but we couldn't say that there is no risk still due to having elevated LPA.
Right. Another question about statins. Do statins raise lipoprotein little a?
They can, not in everybody, but in some people, we do see a slight increase in LPA when they start a statin. But even with that, all of the studies that have looked at that, the evidence points to the benefit you get from being on a statin and lowering LDL and some of the other effects of statins, things like the kind of uh, they help stabilize plaques and they have some slight anti-inflammatory properties as well. All of that outweighs the risk due to slightly increasing LPA. And again, I think that's one of the reasons why it's not often recommended to retest LPA is because we are going to see some fluctuations. And even if there is a small 10% increase from starting a statin, that's probably not going to bump you into a higher risk category if you're already high risk. So yes, they do raise LPA a little bit, but the protective effects you get from statins tends to outweigh the risks from that elevated LPA.
Another question about medication. Does Repatha, and for those of you who don't know what that is, that's a PCSK9 inhibitor, does that reduce lipoprotein little a?
Yep, it does a little bit. I think what is it? I think around 20%, we can see the PCSK9 inhibitors lowering LPA. Again, not in everybody, but in some people, there is a slight reduction in LP little a due to being on a PCSK9 inhibitor, but they are not approved for that. The real benefit from PCSK9 inhibitors is the LDL reduction. So there was some post hoc analysis done in some of the PCSK9 trials looking to see if they lowered LPA enough to reduce the risk of heart attack or stroke. But they found that it didn't lower LPA enough to lower the risk for heart attack or stroke due exclusively to LPA. So might be helping, can't hurt, but they're not approved for that. So it's not something that I think most specialists would take the approach of prescribing PCSK9 inhibitors off-label for LPA reduction.
So I think we got most of the questions. Are we still recording, or should we stop should we?
Yeah.
Do you want to, Eric? Where do you want to go from here at this point? I know you wanted to have a discussion. Should we have that discussion after the recording is stopped then?
Yeah, we could probably pause the recording and just open it up for some conversation.